All right, good morning, everyone. Thank you so much for your time today in joining this presentation. Please text code BREATH to the phone number. I'll also have the slide in the end of the presentation if you did not get a chance to text it. My name is Khrystyna, and I'm PGY2 AmCare resident here at UW, and today we'll be talking about management of chronic thromboembolic pulmonary hypertension. And for the purposes of this presentation, I'll refer to it as Ctf. I hope that by the end of today's lecture, you'll be able to define pulmonary hypertension, recall 5 groups of pulmonary hypertension, describe presentation symptoms of Ctf, describe treatment goals, and recall some common counseling points for pharmacologic agents for Ctf treatment, as well as select appropriate pharmacologic therapy. Start with a definition of pulmonary hypertension. It is a term that describes a group of pulmonary vascular disorders. It refers to a presence of elevated pulmonary arterial pressure and consists of 5 World Health Organization groups based on etiology. The table here introduces the 5 groups I mentioned in previous slides. Here, group 1 refers to pulmonary arterial hypertension. Group 2 consists of pulmonary hypertension caused by left heart disease. Group 3 represents pulmonary hypertension caused by lung disease or hypoxia. And Group 4 includes chronic thromboembolic pulmonary hypertension. And final, Group 5 includes all other causes that really do not fit into any of the groups 1 through 4. Now we will dive a little bit into details with each group before moving on to Ctf. So group 1 generally refers to pulmonary arterial hypertension, which is caused when arteries and lungs become narrow, thickened, or stiff. This is a depiction of normal pulmonary artery, while the blood flow is not restricted. In this next picture, we can see that artery wall is thick and stiff, causing some mild limitation of blood flow. The progression of pulmonary hypertension further leads to restricted airflow, causing moderate or severe blood flow limitation that is causing remodeling and vessel damage. In this case, the right side of the heart must work harder to push the blood through these narrowed arteries that causes stress and can lead to right heart failure and all associated signs and symptoms of PAH. It can include different forms that have various pathological changes in the blood vessel. But generally, vasodilators are mainly used to relax smooth muscle to help restore blood flow. These vasodilators can include calcium channel blockers such as diltiazem or nifedipine in patients who meet specific criteria, or initiation of specific pulmonary arterial hypertension vasodilator therapies, which we will talk about a little bit later. Moving on to group 2, which is pulmonary hypertension due to left heart disease. So in this group, arteries of the lungs are not as thick and stiff as in group 1, but there are problems with how the heart squeezes, causing blood leaving the heart, or how it's relaxing, causing defect and filling. There also could be problems with valve of the left side of the heart. So because of this, the left heart is unable to keep up with the blood returning from lung, causing the backup of blood, which raises pressure in lungs. In this group, as you can predict, treatment includes treating the left side heart at congestive failure. That includes diuretics, beta blockers, ACEs, or ARBs. So treating the heart problem will actually help to reduce pulmonary hypertension in this group. Next, we will move into pulmonary hypertension due to lung disease and or hypoxia. These lung diseases can include either obstructive lung disease, such as COPD, or restrictive lung disease, such as interstitial lung disease or pulmonary fibrosis. Arteries and lungs tighten so that the blood can only go to areas of lungs that are receiving the most air and oxygen, and this tightening leads to high blood pressure throughout the lungs. Here, treatment commonly includes treating underlying causes of pulmonary hypertension, in this case, COPD or interstitial lung disease. Next, we move to Ctf. usually occurs when body is not able to dissolve blood clots in the lungs. So this can lead to scar tissue in blood vessels of the lungs, which blocks normal blood flow and makes the right side of the heart work harder. World Symposium on Pulmonary Hypertension classifies this group as pulmonary hypertension due to pulmonary artery obstruction, which is a more broad general term. However, there are many possible causes of this obstruction, but the most common one is thromboembolism or Ctf. We will discuss Ctf in more detail, but as you may all predict, lifelong anticoagulation is indicated for all patients in this group. And then final group 5 is where pulmonary hypertension is secondary to other diseases that couldn't be classified in the previous 4 groups. Some examples include hematologic disorder, systemic disorder, metabolic, and many other disorders. So now that we went through an overview of the whole functional groups, let's see if we can answer this question. So which pulmonary hypertension group is mainly treated using vasodilators? And we have group 1 through 5 as options. And you can use the chat box to answer. I see some answers. Looks like everyone put A, and that is the right answer. So group 1, where arteries are thick and stiff, so vasodilators are really the treatment of choice mostly for these patients. Now I want to briefly discuss group functional classes, and I will mention this throughout the presentation. The WHO functional class is one of the predictors of survival for patients with pulmonary hypertension, and it's called World Health Organization functional class. As compared to WHO groups we just discussed, classifications here are not based on etiology, but rather on symptoms and limitation of daily activities that patients have. It describes how patient is functioning. If you can see that WHO group is kind of similar to more commonly known New York Heart Association that describes functional class of patients in heart failure. The New York Heart Association and WHO classifications are actually interchangeable, but for purposes of pulmonary hypertension, clinicians refer to WHO classifications instead. So functional class 1 is where patients have no limitation of usual physical activity. Functional class 2 is where patients have mild limitation of physical activity. 3 is where they have marked limitation of physical activity, and 4 is the most severe form where patients are unable to perform any physical activity or they have symptoms present at rest. Some other definitions I would like to mention before moving on with the presentation. First is the 6-minute walk test, which is a testing of exercise tolerance that is commonly used to see how far can patient walk. Normal distance is between 400 to 700, really depends on patient factors. But together with WHO functional class, 6-minute walk distance can be used to describe initial state and then response to therapy. And also, it is one of the predictors of mortality for patients with pulmonary hypertension. For example, the risk of mortality is less than 5 if patients can walk more than 440 meters. Also wanted to briefly describe right heart catheterization, which is a procedure to check the pressure in heart and lungs. It's also called the Swan-Ganz pulmonary artery catheterization, and it's used to obtain direct hemodynamic values that are used for diagnosis of pulmonary hypertension. Ctf is a gold standard, right heart cath is a gold standard for diagnosis of pulmonary hypertension. And here is a little picture showing how it's done. So the probe is inserted into right atrium to check the pressure, then right ventricle, pulmonary artery pressure, as well as pulmonary artery wedge pressure. And we have some baseline pressures here. But one important thing to note from this image is that cardiopulmonary system is a low pressure system to make sure that heart doesn't have to work hard to do its job in the circulation when it comes to exchanging oxygen. So it makes sense that if their pressures in pulmonary arteries are elevated, we will have a lot of symptoms as well as worsening of heart function, and also worsening of lung function as well. So we discussed two groups that define pulmonary hypertension based on etiology. However, pulmonary hypertension can be also classified based on hemodynamic values that were obtained from right heart cath. So there's precapillary pulmonary hypertension that is due to primary elevation of pressures in pulmonary arterial systems, such as pulmonary arterial hypertension. We also have postcapillary pulmonary hypertension that is usually due to elevation of pressure in pulmonary, venous, and pulmonary capillary systems. Some patients can have mixed, but here, as you can see, precapillary includes mean pulmonary arterial pressure of more than 20, pulmonary arterial wedge pressure of 15 or less, and pulmonary vascular resistance of at least 3 units. And this includes groups 1, 3, 4, and 5. So as a reminder, group 4 is our Ctf group. One important note from this slide is that previously pulmonary hypertension has been defined as mean pulmonary arterial pressure of more than 25. However, based on some recent study, the 6th World Symposium on Pulmonary Hypertension proposed to define a new value of mean pulmonary arterial pressure of more than 20 instead of 25 for patients at rest. This is a new change. I believe it was proposed in 2019. So some of the older guidelines may still show it as more than 25. So it's something to note when looking at patients and looking at the diagnosis. So now that we talked about some background on pulmonary hypertension, let's dive into some details of Ctf. Starting with epidemiology, the incidence in the U.S. is estimated to be around 5,000 new cases per year. Some retrospective series studies reported that among 899 patients with a history of pulmonary embolism, approximately 1% developed Ctf. Also, approximately of 600,000 individuals suffer from an acute PE event. An annual number of new Ctf cases is between 500 and 2,500. About 25 people with Ctf have actually never been diagnosed with Ctf, so this is actually a pretty rare disease state. And as we will talk about studies a little bit later during this presentation, you'll see that sample sizes are rather small, not usual sample sizes that we are used to seeing with some of these studies. Now we'll talk a little bit about pathophysiology. But something to note is that pathophysiology is still under investigation, and it's rather complex. There have been several mechanisms proposed. So first one is that Ctf can develop several months or years after an acute PE, which sometimes may be even silent, and it can also form despite continuous anticoagulation or even an absence of new symptoms. It can resolve without complication. However, in small subset of patients, there's some residual clot remains that attaches to pulmonary vessel, leading to vessel damage and growth of the clot. So this presence of clot can further lead to vascular occlusion and small vessel disease, causing the progression of disease as well as signs and symptoms. So now that we have this small vessel disease, the blood flow is redistributed to not occluded pulmonary arteries that causes high stress and blood pressure. This causes endothelial dysfunction that further can increase the pressure, causes tissue remodeling, thickening, and formation of fibrotic tissue that further obstructs blood flow. There's proposed mechanisms suggest involvement of defective nitric oxide levels in patients with Ctf, and nitric oxide serves as a vasodilator, or it has elevated endothelin levels, which serves as a vasoconstrictor. So mismatch and imbalance of these pathways causes vessel thickening as well as symptoms. So overall, these changes lead to disease progression, they increase pulmonary vascular resistance, making it hard for the right heart to work and push against the resistance, leading to ventricular dysfunction and myocardial fibrosis if disease is advanced. There are some other mechanisms, such as autoimmune disorders, hematologic disorders, infections, or inflammation that lead to impaired circulation and development of clots in lungs. Symptomatically, symptoms of Ctaf are really nonspecific and are mainly related to progressive right ventricular dysfunction. So initially, symptoms are induced by exertion, such as shortness of breath, fatigue, weakness. As disease progresses, the symptoms can include angina, syncope, symptoms at rest. Some other signs can include fluid overload, with several cases including enlarged liver or peripheral edema or ascites. Similar with development of Ctaf, diagnosis is also complex and is a multi-step process. So for patients with symptoms are identified, whether they had or did not have prior history of venous thromboembolism, because we know not all patients who had PE will develop Ctaf, and not all patients with Ctaf had previously had PE in their life. And then patients undergo chest radiography and pulmonary function tests to study if there's any airway disease going on. Patients will also undergo EKG or echo to see if there's any cardiac disorders. And then they will have ventilation perfusion lung scan. And ventilation perfusion lung scan can effectively exclude Ctaf patients because it has sensitivity of around 90 to 100% and specificity of 94 to 100%. So this is a preferred initial scan. So if the scan is normal, then Ctaf is excluded. However, if it's not normal or if it's abnormal, then patients undergo further evaluation. As I mentioned earlier, right heart cath is a gold standard for pulmonary hypertension diagnosis and required before proceeding to any other tools or imaging. The other three that I have listed here really depends on the site and what each site prefers using. For example, CT pulmonary angiography will help to visualize clots and also exclude any alternative diagnosis. But again, it really depends on each specific site for diagnosis. So now that we talked a little bit about the background, let's see if you can answer this question. Which of the following signs or symptoms may be representative of Ctaf? And you may utilize the chat box to put your answers in. All right, I'm seeing some E's, and that is exactly right. All of these signs and symptoms can be representative of Ctaf. As I mentioned earlier, symptoms are usually nonspecific and mainly related to right ventricular dysfunction. Great job, guys. So moving on to treatment goals. First, we want to prevent disease progression and further thromboembolism formation. We do want patients to be on lifelong anticoagulation, and that's indicated for all patients. Antiplatelet therapies do not have a role for these patients. So for anticoagulation, we would prefer them to be on warfarin or DOACs. Although warfarin is the traditional agent of choice because it has the most history of use, DOACs are also commonly used, not because they have a lot of studies for Ctaf, but because they have proven efficacy for DVT and PE. However, data specifically for Ctaf is lacking. There's been some retrospective study that show that DOACs that are used post-surgery had higher incidence of VTE compared to warfarin. And in this case, surgery, I talk about specific pulmonary hypertension surgery that we'll discuss in the next slide. However, another retrospective study showed similar results between warfarin and rivaroxaban. So really, as long as patients are anticoagulated and looking at their preference or their background therapies would be preferred. We just want to make sure that they are anticoagulated. We want to improve exercise capacity because a lot of patients who have progressive disease will have limited daily life activity as well as exercise capacity. We want to as well improve their functional class and provide any supportive care that they need. For example, diuretics or supplemental oxygen if they have trouble breathing. So to talk about non-pharmacologic treatment, which is actually preferred first-line treatment for all Ctf patients. And here we have pulmonary thromboendarterectomy, PTE, or also known as pulmonary endarterectomy, or PA, which is a first-line treatment for surgical candidates. And as the picture depicts here, it is a surgical removal of blood clots that is present in lungs. This surgery is a complicated surgery, and it's not done in most facilities. So I believe there's 2 or 3 specialized facilities that provide these type of surgeries. So as you can imagine, many patients would have to travel to be evaluated and undergo surgery. Even though surgery is preferred treatment, sometimes it's not easy to perform it. Here we have 4 levels of clots. For example, level 1 depicts more proximal clot, where it's easy to resect and get it out, where level 4 is very distal, very small. Sometimes it's not easy or even impossible to get that out. For patients who for some reason cannot undergo surgery, another alternative option is balloon pulmonary angioplasty. And it's where a catheter is inserted and then balloon is expanded, and then it helps to widen the arteries to help restore that blood flow. For some patients who have really severe disease, they might consider a lung transplant. All right, and this takes us to our next question. So this is a small case, and I'll give you a minute to read, and then you can put your answers in the chat box. So I'm seeing some D's here in the answer. So let's take a look. So patients does have bothersome leg swelling and fatigue. Labs were normal, really do not have any other information. It doesn't look like he's on any other medication, possibly, but the correct answer would be D, so furosemide and warfarin. So first we want to help them treat their symptoms. So he does experiencing some fluid overload, for which furosemide will help, and all Ctf patients do qualify for anticoagulation therapy, so warfarin would be another choice here. Great job, everyone. So now moving on to pharmacologic therapy for these patients. So for Ctaf, riciguat or Adempas is the only treatment approved for inoperable Ctaf patients or for patients who have persistent disease post-surgery. There's also pulmonary arterial hypertension targeted therapy that are widely used off-label for Ctaf because pathophysiologically the changes that are happening in PAH and Ctaf are quite similar. So for these we have phosphodiesterase 5 inhibitors such as sildenafil. We have endothelin receptor antagonists such as macitentan, bosentan, and ambrisentan. And we have prostacyclin analogs such as epoprostenol or treprostinil. So to start with riciguat therapy, it was studied in CHEST-1 trial, which was a phase 3 multi-center randomized double-blind 16-week placebo-controlled study. Included 261 patients, and they were patients averaging 59 years of age. So 72% of these patients had inoperable Ctef, meaning that they underwent evaluation for the surgery, but they did not qualify. And 28 patients who received surgery but had symptoms after it. This study had 1% of patients in WHO functional class 1, meaning no symptoms, 31% of patients in WHO functional class 2, and 64% of patients in WHO functional class 3. So these were the majority patients, but they also had 4% of patients with severe disease. Their baseline 6-minute walk distance was 347, and this was a 1:2 ratio to receive placebo or riociguat. Their primary point was change from baseline to end of week 16 in 6-minute walk distance. And secondary changes included changes from baseline and pulmonary vascular resistance, proBNP values, as well as WHO functional class, and some other hemodynamic values. So as the result, when comparing patients who were on placebo and patients who were on riociguat, patients on placebo had an average of 6-meter worsening in their 6-minute walk distance compared to riociguats that had a 39 meters improvement. When looking at secondary outcomes, it also shows that patients who were on placebo had a 23-point worsening in their pulmonary vascular resistance, where in riociguat patients, they had a 226-point improvement. Both of these were statistically significant in this case. Also for proBNP values were also improved in patients who were on riociguat group compared to placebo. When looking at functional class, for patients who were on placebo, they had 13 patients who moved to a lower class, meaning lower functional class, so they had symptom improvement, compared to 57 patients or 33% who moved to a lower class in riociguat group. So these results show that riociguat did show improvement for patients who took riociguat compared to patients who were taking placebo. So something important to know that in this study, they excluded any patients who were taking any other pulmonary hypertension specific therapies. So this is monotherapy compared to placebo. Just because this is a specialty medication, I think it's important to understand and know some of the important counseling and baseline information on this drug. So riociguat is guanolate cyclase stimulator, and it's so far the only agent in its class. How it works is that it sensitizes soluble guanolate cyclase to endogenous nitric oxide, and it stabilizes the nitric oxide to see SGC binding. So this promotes vasodilation by stimulating nitric oxide, SGC, and cGMP pathway. It's important to understand this mechanism because any therapy that includes some type of nitric oxide or nitrates, as well as PDE5 inhibitor, which prevent the breakdown of cyclic GMP, will actually promote further vasodilation and may be lethal for patients. So as we can predict, concurrent use with nitrates or 5-PDE inhibitors with riociguats are contraindicated. Fun fact about riociguat is that it can also stimulate this pathway without presence of nitric oxide. So as you can recall, nitric oxide pathway is already damaged in these patients. So really this medication can work even when there's not a lot of nitric oxide present. There is some metabolism happening, and one to note is that CYP1A1 mechanism forms the major active metabolite, however, it's not as active. And this enzyme is induced by polycyclic aromatic hydrocarbons that are induced from cigarette smoking. So for patients who smoke, they may need higher doses of riociguat. So it's recommended to give patients higher doses and see if they tolerate it. Similarly, for patients who quit smoking, as they should if they have Ctef, doses may may have to be lowered because now they do not have that metabolism going on anymore. So this is a good counseling point to think about. Dosing, this is a 3-day, 3 times daily medication dosing. There's some renal adjustment as well. Some common side effects include hypotension, headache, dyspepsia. Some bleeding and CNS effects have been reported. And also important to know that this is a REMS medication, so patients, female patients have to have pregnancy tests before starting the medication. This is a brand name only specialty medication, so the cost is around $155 for 1 tablet, and patients have to take 3 tablets a day, so quite expensive therapy here. So other therapies here and are usually used off-label for Ctef. First is phosphodiesterase 5 inhibitors such as sildenafil, because it was studied in randomized double-blind placebo-controlled pilot study that included 19 patients. This medication helped to improve WHO functional class and pulmonary vascular resistance. However, it didn't show difference in 6-minute walk distance, but again, this was only a 19-patient study. Further, moving on to endothelin receptor antagonists that include macitentan, bosentan, or ambrisertib. Macitentan was studied in MARID-1 trial, which was a phase 2 randomized double-blind 24-week placebo-controlled study that had a total of 80 participants that were averaging 57 years of age. This study included patients with inoperable Ctef. Unlike last study, included patients with inoperable Ctef or patients who were symptomatic after the surgery, so that's one important difference here. Included 23% of patients in WHO functional class 2 and 76% of patients in WHO functional class 3 with baseline 6-minute walk distance similar to previous study of 352. Important difference is that in this study, they did allow other pulmonary arterial hypertension therapies. So 46% of patients were on baseline PDE5 inhibitor. They had also 3% of patients who had oral or inhaled prostanoid therapy, or they had 13% of patients who had combination therapy as well. So this was a 1-to-1 ratio for patients to receive placebo or macitentan. Their primary outcome, unlike previous study, which included 6-minute walk distance, here their primary outcome was pulmonary vascular resistance at week 16. For their secondary outcome, they had included changes from baseline and 6-minute walk distance, for dyspnea score, WHO functional class worsening, and other secondary outcomes. So as the result, for patients who were on placebo group, pulmonary vascular resistance improved by 86 points, where in macitentan group it improved by 206 points, with this result being significant. Looking at 6-minute walk distance, patients who were using placebo had a change of 1 meter compared to patients on macitentan group had a change of 35 meter, with this result also being significant. When looking at functional class, really not much difference. Patient 40 in macitentan group, 100% of patients did not have any worsening of symptoms, compared to placebo groups where 93% of patients did not have worsening and 3% of patients had worsening of symptoms. Macitentan was not the only drug studied in this population. There was a benefit trial, which was a double-blind placebo-controlled trial that included inoperable or persistent post-PEA surgery patients. Included 157 patients, but no other baseline therapies were allowed in this trial. So results show that pulmonary vascular resistance improved in treatment group. However, 6-minute walk distance wasn't different. However, bosentan, even though it didn't have improvement in 6-minute walk distance in this trial, they did a meta-analysis that included 10 observational trials and 1 randomized control trial, which was the benefit trial we just talked about. A majority of those patients were with inoperable Ctef. There, it showed that there is some difference in 6-minute walk distance that favors treatment with bosentan. And last trial in this class was AMBER-1 trial that was randomized double-blind placebo-controlled trial, included patients with inoperable Ctef, included ambrisertib versus placebo. Study actually was terminated earlier because of screening issues. However, some data that was obtained showed that there was an improvement in 6-minute walk distance as well as some hemodynamic parameters. Similar to benefit trial, this trial also did not include background therapies for patients, so it was just one treatment compared to placebo. To talk a little bit about macitentan as a medication, so it is an endothelin receptor antagonist. It blocks endothelin 1 from binding to endothelin receptors on the vascular endothelium of smooth muscle, and it causes vasodilation. There's also some drug-to-drug interactions. However, compared to riciglad, this is a once daily dosing. Some prominent side effects include peripheral edema, headaches, liver toxicity, sometimes respiratory infection. This is also a REMS medication, so caution must be made for these patients. And this is a $423 per one tablet, so also quite pricey treatment for patients here. Bosentan is actually a twice daily dosing. It requires some more monitoring for liver function tests. And ambrisertib is also a once daily tablet. Macitentan is brand name only for now. The other two are actually generic. Now that we briefly talked about some of the treatments, we have another patient case here, and I will give you a minute to read it over, and you may utilize the chat box to put your answers in. We have some A's. Okay, perfect. Thank you. Any other ideas or thoughts? All right, so this was a little tricky question. So we have D. Thank you. So we have D. All right, perfect. Like I mentioned, this was a really little tricky question. So when looking at this patient here, he has some baseline therapy that includes isosorbide mono. So that's a nitric oxide related medication. And as if you can recall, riciglad is contraindicated to be used with either PDE5 inhibitors or nitric oxide inhibitors. As well as sildenafil, there's also a contraindication with nitric oxide specific mechanism. So even though riciglad is a preferred therapy for Ctef patients, there's some drug interactions that we have to avoid. Zoltiazem wasn't studied for Ctef. There's sildenafil and other drug interactions, so that leaves us with macitentan as the only treatment option available. Thank you, everyone. Now we're moving on to other class of agents, which include prostacyclin analogs that are epoprostenol or treprostinil. Treprostinil was studied in a subcutaneous treatment for severe non-operable chronic thromboembolic hypertension, or STREF trial, which was a double-blind randomized controlled trial that included 105 patients. Participants were a little older compared to the other trial, 64 on average. Study included patients with inoperable or persistent or recurrent pulmonary hypertension after the surgery. They had 91% of patients in WHO functional class 3, and baseline 6-minute walk distance was way lower, 303, compared to other trials we talked about today. This is another trial that allowed baseline therapies as an interesting. Riociguat was also included as part of that baseline therapy. So because patients were a little bit more severe, they decided to do an active comparator. So they had 1-to-1 ratio for patients to receive either a high dose of treprostinil or a low dose of subcutaneous treprostinil. The primary outcomes was change in 6-minute walk distance from baseline to week 24, and their secondary outcomes included changes from baseline to week 12 in 6-minute walk distance, changes from baseline and WHO functional class, as well as some hemodynamic parameters as well. So as the result, patients who were on high-dose treprostinil, their 6-minute walk distance at week 24 had a change of 45 meters. Compared to low-dose treprostinil, the change was 3.8, which was statistically significant change for this patient. However, for patients who were using either high or low dose, the 6-minute walk distance was not that different between the two. The change of 27 was noted in low dose subcutaneous treprostinil, and a change of 32 was noted in high dose subcutaneous treprostinil. Comparing WHO functional classes, we had 51% of patients in high dose that improved functional class, and we had 17% of patients who improved on low dose treprostinil. They also looked at pulmonary vascular resistance that also showed improvements in the high dose compared to low dose group, with this result also being significant comparing the two. Something interesting to note of in this study was that the 6-minute walk distance at week 12 was really not different between the two groups. However, by week 24, it had a quite big difference between the two. And authors said that it's possibly because there is that transient vasodilation when patients are started on subcutaneous treprostinil, but then it wanes with time. And so patients on high dose keep having this positive effect, where patients on low dose lose that efficacy for subcu treprostinil. As always, little background therapy on treprostinil. It is a prostacyclin analog, so it's a direct vasodilator of pulmonary and systemic arteries, but it also causes inhibition of platelet aggregation. It does have some hepatic metabolism as well. There's various dosage forms available, so it can be inhaled, oral therapy, IV, or sub-Q. Specifically for this study, sub-Q was used, but a lot of the times IV or sub-Q are commonly used for PAH patients. Some side effects include peripheral edema, headache, jaw pain, and flushing. Important to remember that these medications are continuous infusions, so whether IV or sub-Q, and there's specific pumps that have to be obtained for patients for these therapies. It is important to remember that therapy should not be stopped abruptly, because this agent has a half-life of 4 hours. So if the therapy is stopped abruptly, patient can experience some rebound pulmonary hypertension if we stop this therapy. This is also a therapy that's more on the expensive side for patients, because it requires a pump, it requires other baseline monitoring and support for patients. And this is also injectable therapy. So something to consider for these patients when deciding therapy. Another medication that is not really mentioned in guidelines but has approved use for PAH includes selexipag or Uptravi, which is a prostacyclin receptor agonist. They had a study there was a double-blind randomized placebo-controlled multi-center study in Japan. that included inoperable or persistent recurrent Ctf patients. The N was 34. 52% of patients were on baseline PDE5 inhibitors or ERA therapy. After week 16, there was no significant difference in pulmonary vascular resistance and 6-minute walk distance, but it showed some other hemodynamic value improvement. But for now, this agent is not used for Ctef, but it is used for PAH, so one of the difference here. So as a summary, pharmacologic therapy includes riciguat, which is the only approved therapy for Ctef in the US. Interesting fact, in Europe, they just approved treprostinil subcutaneous use for Ctef patients. Phosphodiesterase 5 inhibitors are on the cheaper side, more affordable side for these patients. Important to note, sildenafil dosing is 3 times daily, but use other PDE5 inhibitors, for example, tadalafil that's used daily. Endothelin receptor antagonists are oral medications. Of these, macitentan and ambrisentan are taken once daily, and bosentan is used twice daily, but it also requires monthly liver function tests. So something to keep in mind for patients who do not have medical coverage, because it does require them to come in for labs every month. And prostacyclin analogs, either ibuprofen or treprostinil. So treprostinil is actually studied for Ctef. Data from ibuprostenol comes from a study that studied PAH, but included patients with Ctef, so very small study population. But it's also an intravenous therapy that also requires an infusion pump as well. When thinking about dual therapy for these patients, we do not have a lot of data available. They had a cohort study that included 183 patients that did not show mortality benefit after 5 years. There was a retrospective analysis that included 139 patients that did show some improvement in clinical status, exercise capacity, and hemodynamic improvements in patients with inoperable Ctef. But right now, dual therapy is considered in expert centers for treatment of severe Ctef as well. Something important to note that sometimes physicians will use this therapy to lower hemodynamic values for patients before surgery, but there's really not a lot of data behind it. And sometimes these baseline therapies do delay patient evaluation or even surgery. And as we know after this presentation, that surgery is the #1 curative treatment. So really something to consider and educate patients on. So this brings us to our next question, another patient case, and I'll give you a minute to read it over and use chat box to put your answers in. This is a more severe patient. He's currently in functional class 4, so that's symptoms at rest. A more severe patient that's already on anticoagulation. Right, we have 1C. Great, thank you. We have another C, so that is actually the right answer. So riciguat and sildenafil should not be used together. Select CPAC didn't show any benefit, and this is a severe patient who functional class 4, so some centers do prefer dual initial therapy, so that would be the right choice for this patient. Thank you. So as a summary, for Ctef patients, anticoagulation should be initiated for all patients, whether they had surgery or not. All patients with CTEPH should be evaluated for surgical intervention. As for now, ribociclib remains to be the preferred therapy for inoperable or recurrent post-VTE CTEPH patients, and monotherapy versus dual therapy should be really individualized for each patient. Important to remember that CTEPH requires comprehensive care for patients, so that includes anticoagulation, side effects, as a lot of these medications have a very common bothersome side effects for patients. Also remembering that there are some drug interactions that are needed to be monitored for and avoided. CTEPH is considered to be a lung disease, so vaccinations are important, so patients should be up to date with their pneumonia shot, as well as smoking cessation that should be counseled and talked to for each patient. And this is a team approach. As I mentioned, there's only 2 or 3 authorized centers that do perform these CTEPH surgeries. So patients do require a lot of work with their social work to help coordinate their travel, recovery, and surgery stay for them and for their supportive family members. So a lot of factors come into play when we take care of these patients, but it's important to be aware of every aspect of it. And that concludes my presentation. I wanted to thank you all for your attention and participation, and I also wanted to thank you, Catherine Decker, for her input and help with this presentation as well. Here's the code breath that you can text to this phone number, and I'll be happy to answer any questions you guys may have. Thank you, Lori.
All right, well, if there are no questions for Khrystyna, thank you everyone for attending Grill today. We will go ahead and wrap up.
Thank you, everyone.
Great job, Khrystyna.